So I'm Kelly. I work for FCMS on the northwest coast of England. I work in inclusion health as part of a nurse-led team that supports people experiencing homelessness and multiple disadvantage. So just a little bit of background about myself. I'm an A&E nurse by background, by way of specialist community public health nursing, on to safeguarding practice in the NHS for a long time, and then on to FCMS, where I'm now a trainee advanced clinical practitioner, and I've just been newly made the safeguarding lead for the complex lives unit, so I might be coming into more of these forums, so it's lovely to be here with you all today. So I've been doing this current job for about 3 years, and I have to say that it is the best job that I've ever done, ever. It is more than a job, is inclusion health. I know that's a bit trite to say sometimes, but it can be quite challenging, but you need such a depth of passion and personal commitment, which I'm sure you all appreciate, really, to drive care for these patients. So just this morning, I'm going to give you an overview of the service and how we came into being, the context of our work and that trauma-informed approach and complex multiple disadvantage, which I'll discuss later, and then I'll take you onto a patient journey so you can kind of see it all in action. I am really, really sorry about the dullness of the slides. They're more of a place marker than anything. I'm much more of a talker. If you can see me on your settings on your screen, I do apologise for the hand wafting. I do a lot of it. So I'm just going to start sharing the presentation now. Okay. Hoping everybody can see that. Give a thumbs up or anything. If so, that's perfect. Okay. So just a quick, oh, wonderful. Thank you, everybody. I just need to make sure I can actually skip it on. Right, there we go. So just thank you, everybody. So just to give an overview, so we were initially a pilot project that we were asked to set up a service in response to a really sadly preventable death of a person experiencing homelessness. So this was as a result of an infected wound that had led to IGAS, which is invasive group strep A, if you're not familiar. So why FCMS? Well, we were already really established in the local area we already had a wound care service that we offered. So that was the initial background to it. We also coordinate and run the out-of-hours services and the urgent treatment centres across the locality, and with the administrative front door of the local A&E as well. So we were really well placed to respond to people experiencing homelessness who do have higher instances of accessing urgent and emergency care. So the infrastructure was already in place, and I'll give you a really good for instance of that. So our service, so FCMS run the local care coordination service, which offers what used to be called AVS, so the acute visiting service for the ambulance crews. So if they had a patient that didn't need secondary care, they call the one coordination line that FCMS run, and they can get access to the out-of-hours doctor to provide medical input. Now, we decided to piggyback onto that. So when ambulance services approach a person in the community who's homeless, they don't know where to refer on, they don't necessarily need secondary care. So now they just ring the one number that we already coordinated and make a referral to our service. So really little initiatives like that we already had the infrastructure as an organisation in place. I will credit my husband. He would kill me if I didn't say that. He's a paramedic. It was his idea. So well done him. So the urgency of the need for this service, so the seed was there for the idea, but it was really accelerated by the pandemic, which just exposed to commissioners and providers the extent of the inequalities for people experiencing homelessness or other excluded groups, that they couldn't access healthcare. And if you've been told to safely isolate at home, how difficult that is when you don't have a home to isolate in. We also worked alongside a couple of programmes that were running in Blackpool. These were ADA and Changing Futures. So I don't know if you're familiar with Blackpool. It is its own little idiosyncratic place. I only intended to come here for 6 to 12 months, and 13 years later, here I still am. Oh, I think something has just popped up, but I can't quite see what that was. I'm really sorry. If it is a question, I will, let's look, sorry. No, that's fine. I'm really sorry. Unfamiliar with Zoom, so it's a little bit clunky for me. So if there's any questions, I'll come to them at the end if that's all right with everybody. Just that I'm not doing that awkward in and out of the slides. So yeah, so coming on to Blackpool, it is a very unusual place. For whatever reason people come here, none of these are my reasons. So they have like childhood memories, or they think it's like an escape. There's the practicalities of really cheap housing and also like seasonal cash in hand works. We've got a really, really transient, large, unstably housed population. It's in the top 10 indices of deprivation, and some of the wards are actually in the most deprived areas of England. It's got high rates of drug-related crime, high rates of drug-related death. So we became a pilot site for one of the Home Office OHID ADA initiatives, and it's also a Change in Future site. So it's two completely separate presentations just to talk about those. So I have put links on the slides, which I hope will be shared, that you can see some of the data if you're interested. So briefly, what the two programmes aim to do is offer this holistic wraparound support for people. So our role as a service in that was to offer holistic health assessment and then provide care where current Main Street services weren't quite meeting the needs of the people, because we could mitigate some of the barriers to access. So in terms of making fast track referrals, cervical screening, long-term conditions management, wound care and acute needs management. It really is very much an individual needs-led offer. So in terms of the operational overview, it's nurse-led because we have the focus on the holistic health approach with the skill mix there as described. And we started the offer in Blackpool, but we've now expanded to the other two localities on the Fylde coast, which is Fylde and Wyre. So again, if you're not familiar, Wyre is like Fleetwood and Knott End and over Wyre, which is a very strange place. There's a ferry involved to get to it. And then Fylde is the Lytham and St Anne, so very, although like a stone's throw away from each other geographically, markedly different in terms of the demographics, the service availability, the access. Like I mentioned, there's a ferry involved to get to one of the places, and the housing pool that's offered as well. So we couldn't just cookie cutter what we were doing in Blackpool. We had to make the service fit the inequalities that were in that area, because that is the aim of our service, to reduce those inequalities. So we offer a range of drop-in clinics, outreach. We've gone out in a mobile van. We have a converted coach that we deliver healthcare in as well. And we co-locate, which is one of the most important things, with hubs, with partner agencies. So this is non-health agencies as well. But we also work with the Hep C teams, the sexual health teams and drug and alcohol teams, because we're trying to reach out to those that struggle to access mainstream healthcare. So we're talking people who inject drugs or use substances, people who are experiencing homelessness, sex workers, etc. It's an in-hour service for that reason, because our approach is about the key to multiple disadvantage care is about multi-agency work. It's not about individual services working in silos. And I know I've worked in safeguarding a long time. We hear that all the time. It keeps coming up, but it's still happening. So we're trying to reduce that silo working by having a hub offer to these patients. So although there are other inclusion services who do like an out of hours offer, our focus is on the multi-agency. So ours is just Monday to Friday, 9 till 5. And today we have had, well, to the date that I made these flat slides, which is a couple of months ago, we've had over 1,000 referrals, which is probably more than that now. We're becoming quite well known and liked and well used as well. So I'm just going to explain a few points, and some of you will already be aware of this, so that's great, and hopefully this will just be a refresher, but some people might be brand new to these terminology. So I just want to explain some of the terms so we've all got a shared understanding, because it's all right me going on about them when you think I don't even know what that means. So multiple disadvantage, what kind of do we mean by that? So it's really like a catch-all umbrella term that just describes how a person's current circumstances have been affected by previous experiences, and we're talking negative experiences here, unfortunately, and how that leads on to that person facing structural inequalities that leads to poorer outcomes. Now, there's just a note to say that some of the terms in themselves, like complex and disadvantage, sound really problematic because it's coming from that deficit outlook. But it's an important distinction that it's disadvantage faced by the individual, not the individual themselves. And it's actually the systems that are causing the disadvantage, which I'll come on to in a moment. So some of these negative experiences and poor outcomes are, a whoosh there, I've forgotten I put that in. Any of these, and you will recognise these already as all experienced safeguarding practitioners in some of the patients that you do or have worked with. And it's really important just to reinforce that multiple disadvantage is a systemic issue, not an individual one. So if we look at this range of experiences and imagine if we met this person in practice and start thinking about the services that you're aware of, you might work in, you might have worked in before, that's 8 individual services. And again, coming back to that working in silo, 8 individual services for this person. So that's 8 different referrals, 8 different appointments to keep, a minimum of 8 different people to meet. And let's not come into how many people they would see during that process. So you can see how it just widens that inequality gap there of all of these needs, very significant, all intersecting,
right, baby,
but all individual services. So if we take a really common example of dual diagnosis, so mental health and substance misuse, I know there's obviously mental health and substance use providers on the forum today. So 90% of our clients have these issues, coupled with contact with the criminal justice system, contact with having homelessness, having physical health needs. So it's thinking about where we would even start tackling these issues. So if we start with housing and house the person, it might improve their physical, their mental well-being, might reduce their substance use, might, fantastic. However, they might not be well enough to access the housing support. When we talk about well, we're thinking emotionally, physically, their resilience. So their anxiety and depression would go up, their substance use may go up, their physical and emotional well-being would go down. It just further excludes them from services. We have a couple of examples of that at the moment with people we're working with. A chap who is rough sleeping, poor physical health, his mood is so low at the minute. Housing have told him that phrase that sends shivers down my spine, not engaging. He's not engaging because he's not well enough to engage. He doesn't have the emotional resilience. He doesn't have the physical resilience. And when we ask why, and I'll come on to the importance of asking why in a second, is that he can't keep hearing no. So he's been told these are the things you need to do. You need to show up and show us that you are engaging, but he can't keep hearing a no. So this is just making him spiral. So we need to look at how we intersect all of these issues, which will come out in the patient journey. So what do we mean by trauma-informed approach? I don't know if any of you have seen the Lads Like Us impression. I'm fresh off the back of seeing this yesterday, Lads Like Us presentation. So if you haven't, please do check them out. They have a grime track. Again, not sure if you're familiar with grime. There was a little hotbed of grime in Blackpool about 10 years ago in the looked after children that I worked with. Anyway, they've done this track called Ask Why, and it's a great introduction to what I want to talk about now in terms of trauma-informed approach. So when we talk about multiple disadvantage and these previous experiences that led to these poor outcomes and have introduced these structural inequalities, we've got to start as practitioners by asking why. So we've got to kind of open our ears to the trauma and more importantly, incorporate the acknowledgement of that trauma into our practice. So again, this is just a whistle-stop brief about trauma-informed approach. And those of you who work across Lancashire might already be familiar with this because there's a real push in Lancashire to introduce this across services. So in short, what we mean here, and I'm really sorry if I'm teaching you to suck eggs and you're already aware of this, but it's just in case it's, puts us all on the same page. So trauma as chronic levels of toxic stress, so that maladaptive natural functioning, that cortisol that might be from adverse childhood experience or adverse adolescent experiences, or as research is showing, a single episode of a traumatic life event, so PTSD, single episode leading to PTSD, which causes injuries in our bodies and our brains, which is going to then change the way we think, the way we feel, the way we behave, until we recover from those injuries. And that's the important part, until we recover from those injuries, much like any other injury that we've had. So this then leads on to impacting on emotional regulation, processing, social functioning, which essentially is just sort of a fancy way of saying how we present ourselves to the world and how we deal with challenges that we face. So the trauma-informed approach is mentioned in the NHS long-term plan, it's mentioned in the NHS implementation plan, and there was a focus on mental health and behavioural services, but it's now expanding to all agencies and services, particularly as I've said across Lancashire, they want to make it the golden thread, it's called, that runs through services, and sign agencies and services that work with people facing complex needs or multiple disadvantage to sign up to a pledge to deliver trauma-informed care. And it is really important to think about the services that you're in, that those that don't offer a trauma-informed approach do risk excluding those, such as the experience we mentioned before with housing, risk excluding those who have had these experiences, and further compounds that disadvantage and widens the inequality gap. So the QR code there, it's not to the grime track, I am sorry to say, it is just to the Lancashire Violence Reduction Network 7-minute briefing. So if you just think about the services that you work in or have worked in, do a little benchmark in your head of how they measure up to that trauma-informed approach. We know that people facing difficulties in emotional regulation and processing disorders, they don't really fit with really busy and overstretched health services. And we know we're all busy and we're all overstretched. So as well as our individual practice, the trauma-informed approach involves adaptations of service delivery. So these are just some of the approaches that we use in our service to mitigate these. So these range from really practical flexibility of appointments. We don't have a DNA policy. We don't really have appointment timings. It's just a come on this day. How we communicate information is really individually tailored. We don't have a one-size-fits-all approach. So we'll offer written information, we'll offer pictorial infographics, we'll offer text messages, we'll give it verbally, we'll give it to support workers and next of kin if that's what they need. So this is things like the treatment plans, medication regimes, safety netting advice. And I feel like it goes without saying that we build trust and we show empathy, but this can be really, really challenging in people that are distrusting of services and are reticent to access and are downright sort of critical, and I won't say aggressive, but can be, you know, they've had bad experiences and they're going to let you know about those bad experiences. So we show up, we do what we say we're going to do when we say we're going to do it. We don't make promises we can't keep. We show patience, and above all, we're human. We're not clinical, we're not strict. Well, we're clinical obviously, but we're not strict. We offer real human interaction. And one of the important things is about exploring ambivalence. And it is the most important thing for me. And I don't know if you know much about change management theory, particularly, well, obviously those who work in substance and misuse and recovery and addiction will know this, but exploring ambivalence is not so much having professional curiosity is a phrase that we hear a lot, and I heard this at a conference a little while ago, so I'm going to pinch it now. Is it's not about professional curiosity, it's about human curiosity. Coming back to that, asking why. Are we just going through the motions and accepting a no, I don't want to do that as a final answer? So we had a lady a little while ago who needed some emergency care, and she refused. She had capacity. She's like, no, I don't want to do that. And when we stopped and asked her why, it was because she was rattling, and the pain of withdrawal was far more significant to her than anything we were telling her about her health needs in that moment. So we got her a rapid assessment for a script. We contacted the pharmacist in the emergency department. We contacted the consultant and the nurse in charge and arranged for this wraparound care. So this lady wouldn't be withdrawing in the emergency department, and that she'd actually be protected. Now, that lady's no wasn't a fully informed no, because she didn't know that other choices were available to her, but us asking the why really opened the door to see that there were other choices that she could make. So that exploring ambivalence is really important. So as a team, these are some of the areas that we assess in terms of the holistic health assessments that we do. So on the surface, you can kind of see there that these are kind of our like traditional or like straightforward safeguarding needs. But if we just start to talk about self-neglect for a moment, you can see that actually some of these other, like the physical health needs, can become an indication that there is a safeguarding need there as well. Now, that's not to say we're removing kind of the autonomy or liberties of our patients in terms of not managing their own health needs. I mean, it's really tricky to manage going to an asthma review when you're struggling to wonder where you're sleeping every night. But self-neglect is a really significant issue with our patients. So it can be caused by any of these things here, which we, again, pretty much sums up a lot of the patients that we see. And an adult social care referral would be warranted for self-neglect, like any other safeguarding concern, if it had the potential for significant harm. And even more so for the people that we see that are facing these additional difficulties, that, you know, things such as illness, addictions, emotional regulatory processing disorders reduce people's ability to manage their own safety and needs. So these people have, like we've said before about the lady who went to A&E, they've got capacity, just not choices or agency. So they've got a much lesser ability to implement the measures to protect themselves. So that's why they need the additional support. So we work with two fantastic social workers who work on our rough sleepers team. They are really sensitive to substance misuse issues, self-neglect, and they really make it easy for us. But again, if you take anything away from what I've said today, this document is fantastic. It's for people experiencing homelessness, but it's a brilliant self-neglect document. It tells you when to refer, it tells you what to write. One of the social workers told me I'm far too polite. I said, please, can I have a section 42? I've got to demand it. But I'm not a really demanding person, but that's what she told me. But this is a really brilliant resource. So a bit of bedtime reading if you like it. So just, I know I've not much time left. I did think I had half an hour, not 20 minutes. So I'm just going to take you through a little patient journey. So this is Alan. Alan is not his real name, but Alan is a real person. So Alan was brought to our team by the lived experience team, who are a fantastic peer support team. He was sleeping on the seafront in a tent, not a brilliant environment you can imagine on the kind of wild and windy Fylde coast. He was a white male in his late 40s, and if you know anything about life expectancy and people experiencing homelessness, you will know he's one of the much older of the cohort. So we assessed him in all the areas, so these ones that we've done before, and it took about an hour and a half just to do the assessment, not to do any of the direct care or the follow-up afterwards. And these are some of the things that we found in Alan. So we had sort of leg ulcers with a PVL, Staph aureus infection, asthma, the peripheral vascular issues, high risk of malnutrition, continued injecting use, mobility issues. We'd said he was rough sleeping. We found out he was Hep C positive, and he had low mood. Now, when I did this in practice, I used the annotation to do the little drawing between things, but it just became a mess and was very confusing. So I'll just describe it. So you can see how these are intersecting just by me kind of explaining now that obviously the rough sleeping and the injecting drug use was leading to the leg ulcers and the vascular issues. Again, the rough sleeping had led to the infection. Infections were obviously having an impact. His Hep C and his leg ulcer infection were having an impact on his nutrition, as was his asthma and COPD. These were all having an impact on his low mood and his mobility issues. The fact that the housing options, as I said before, the housing options building is in another town, so the Wyre area is quite a large area, and this is about 2 bus rides away. So he just didn't have the means to get to go and access housing because of all these things. So as you can see, his motivation was getting lower and lower, as was his mood. So all of these intersecting issues, where we're going to tackle them. So our one singular team, co-located in a hub model, were able to, before Alan had even left the building, implement all of these. So we got him wound care and infection prevention measures. This was things, so not just the clinical things like dressings, but these were like bedding, towels, wipes, cleaning products for himself and his surrounding environment. We did an asthma review and found that it was far more practical to put him on a MART regime and give him one singular inhaler than having lots of things to deal with. We arranged for a vascular outpatient appointment, and not just the appointment, we arranged the transport, we arranged how he was going to find out, we arranged him to have a butty and a brew when he went up there to wait as well. We implemented a nutritional care plan, we facilitated drug and alcohol worker engagement, that word again. The information that we got about his health needs enabled us to write a letter, well, an email or followed by a phone call to housing to get him emergency accommodated under a duty that day. And we even got him a flat viewing at the end of the week, and we arranged the Hep C team to come down, not only do the medication, but we've had like the fibre scan done. So all of these actions we did to safeguard Alan, we didn't need a safeguarding referral. We just needed those other support agencies to come together to look at the multiple disadvantage, look at what the areas of need were and how we could support Alan in mitigating these, to looking at his barriers and his strengths as well, because he really was motivated. It was just, again, it was just that door opening that he needed. And again, with his low mood, at no point did we, at this point, we didn't offer him any formal mental health referral. We just sat with him with time, with patience, with that human interaction, just to show that we were there and we would show up for him. So thank you very much.